Okay, the recording has started.
Thank you, Karen. So welcome everyone, and thank you. This is the Rule Advisory Committee meeting for Senate Bill 822, Network Adequacy. My name is Brooke Hall, and I'm the policy analyst leading this rulemaking. In the interest of time, we're going to forego introductions today, but just an important note before we get started. This morning, I noticed that the PDF version of the rule that I sent out didn't include some of the recent updates. For some reason, when I printed to PDF, it didn't include the deletions from the rule. So to ensure accuracy, Karen's going to display a Word version of the rule, which may be slightly different than the one that you saw. But after the RAC, I will send out an updated version of the rule to all participants that includes all of the changes. So if there's any questions or concerns about that, let me know. And just some meeting etiquette. Please stay muted unless you are speaking. If you're joining us via Teams, please use the raised hand feature if you'd like to comment or ask a question, and I will call on you. And when speaking, please introduce yourself and the organization that you represent so we can clearly capture who's speaking for the record. Our agenda today, we're going to review comments received. I'm not going to ask people who provided comments, to provide an overview. I'll just give a brief overview. We will review the draft rule. We will review the statement of need and fiscal impact, and then there'll be some time for public comments and next steps. Any questions before we get started? All right, hearing none. So public comments. We did receive 5 public comments after the last Rule Advisory Committee meeting, one from the Oregon Academy of Family Physicians, one from MODA Health, one from Basic Rights Oregon, Cambia, and also Oregon Independent Mental Health Professionals. The comments focused on concerns about the network adequacy rule itself and their impact on access to care. But Basic Rights Oregon did provide some feedback about justifications for filing a temporary rule. The letters were included in the materials sent out for the rulemaking, so feel free to read them in full if you would like. And again, I'm not going to ask RAC members to provide an overview of their comments, but if anybody would like to add anything, please feel free to do so. All right, so we'll go to the next section of the agenda, which is reviewing the draft rule. All right, so in the version I sent out, again, I did highlight the changes that were made. As you'll see here, there are updates to the rule numbers made throughout because we do have rule numbers now for some of the new rules, and so those updates have been made throughout the rule. The first substantial change is right here in 2. And we added this statement that's highlighted. It says these requirements apply to the adequacy of provider networks used to deliver services in a health benefit plan's service area. This change was made as an attempt to address some of the concerns that were discussed in the previous RAC about the previous statement, including out-of-state networks in the application of the rule. And so this is trying to address the concerns that were brought up by some of the carriers about the previous statement that was here. Is there any feedback about this addition? Does this better capture what we're trying to go for here? Gary, go ahead.
Yeah, I agree with that, Brooke. I like the way you did it. Thank you.
Thanks, Gary. Any other feedback about this change?
This is Antoinette from Cambia. We like and support it. So thank you for listening and narrowing the scope.
Thank you, Antoinette. All right, let's scroll down. I think the next changes are to the definitions section, to 1F and G. If you scroll down, Karen. Right here, we just added that any updates to the health professional shortage areas or low-income zip codes after January 1st, 2025 will be published in a bulletin and made available on the division's network adequacy website. Okay. So any questions about this addition? Okay, and if you scroll down, I think there's one more change to this rule number, Karen. And here in J, under the definition of county, I just updated where the federal definitions of those county classifications can be found. So this is the correct citation for where those definitions can be found in federal rule. And I'll just point out that this 42 CFR 156.230, I believe it is the Medicare rule, but CMS does apply the same definitions. They use the Medicare rule for the QHP rule as well. And so that is the correct reference there. So any questions about that change? Okay, we can scroll down. I think the next changes are in the network adequacy reporting requirements section. Yep, keep scrolling. Yep, keep going. All right, it'll be right here. So the first change is to 2B. This is an addition we included indicating that carriers should include information on telemedicine, including a breakdown of the percentage of telemedicine delivered by Oregon-based providers who also provide in-person care versus the percentage delivered by telemedicine-only providers. This was a suggestion in one of the comment letters by a RAC member, and it was included in the language because it allows the division to better evaluate the adequacy and continuity of care within networks, ensuring that telemedicine complements rather than replaces in-person services. So any questions, comments, feedback about this change? Okay, if we scroll down. Okay, I highlighted D, county served, because we did receive feedback from a RAC member that this language may be too vague. But when reviewing it for changes, I actually questioned whether we needed carriers to provide us information on the county served, because if you scroll up, Karen, just a little, in C, you'll see that we're already asking for the street address and zip code of the provider or facility location, which we can get the county from the street address and zip code of the facility or of the provider or facility. So my question is, do RAC members believe this is the requirement to have carriers provide the county served duplicative, or do RAC members believe carriers should also explicitly indicate the county where providers serve enrollees? I'm just hoping to hear some thoughts. No thoughts? Would anybody have any issues if this language was removed from the rule?
This is Antoinette from Cambia. Oh, I'm sorry. I keep not raising my hand. So Gary, go ahead.
So Gary Hawley, Pacific Source Helplines. I agree with removal. I won't have any objection to that. Unless there's some reason there's a summary and a report that needs it at the county level. I think zip code gets you there.
Yeah. Okay, thanks, Gary. And Antoinette, go ahead.
Yeah, I was just about to say we feel the same way. And we are also fine with it being removed. It's less data. Well, it's less information that may not or may help. So, yeah.
Appreciate your thoughts.
Mm.
All right, so the next change was in this section 2J, which previously had the information that we added on cultural competency. That language, if you scroll up, Karen, it was the highlighted section above. Yep, this right here. So this language was all removed from the rule because as we discussed at the previous RAC, it became kind of duplicative and it conflicted with the new behavioral health composition and reporting section. And so it just, it wasn't necessary to include this language in the reporting requirements when we have that new behavioral health composition section, which serves the same purpose. So any questions about this deletion? Okay. And then Karen, if you scroll down all the way to the bottom of this rule, I believe there's one other highlighted change at the very bottom. We added a section 4 indicating that a carrier may request a waiver from the reporting requirements if the network has 0 enrolled lives in Oregon as of the reporting date. This was, again, a request of a RAC member in the comment letters, and we felt this was a good addition to the rule, so we added it to the rule here. Any questions about this? Antoinette, go ahead.
Yeah, definitely support the addition of the waiver, but would that be part of the, would there be a separate form created as part of the reporting template? Or that's something that the DFR with carriers that have chosen to be part of the network adequacy template reporting work group will address?
Yeah, that's a great question, Antoinette. And I think that's something that the network adequacy reporting work group will request, because there's also the same question in regards to the exception process in health professional shortage areas and low income zip codes, whether we need a separate kind of Word document for when a carrier requests a waiver in an area where they're unable to meet standards in health professional shortage areas or low income zip codes. And so I think that'll be a question for the work group as to what that waiver process in both of those instances should look like, and whether it will require a separate form, because currently, and correct me if I'm wrong, Mark, it's not captured in the quantitative data reporting template that we currently have.
Oh, that sounds correct, Brooke.
Thank you.
And another question, although this is in rule, if part of the work group is decided that it just may be more efficient to just indicate 0 and in the data template, and with that 0 basically indicates that there's nothing to report. I just want to make sure that although this is going to be in rule, when we're discussing how to practically implement this, and we find that just indicating a 0 in a template may be sufficient, that we're not stuck to this because it's in rule.
Are you saying because it says that a waiver, and if if you're just indicating a 0 on a template, then that's different than maybe a waiver process?
Yeah, like during the work group, we are sort of kind of discussing how to put this in practice, and we end up concluding that just if a carrier puts 0 to the DFR, that would mean that there's nothing to report. That's sufficient rather than going through a formal waiver process. I just don't want us to be stuck by this because it's in rule.
Yeah, I agree with that, Antoinette. And we will have, just for those to be aware, we were asked to move, the work group meeting was scheduled for this week, I believe on Thursday. We were asked to move that because it conflicted with another RAC that is ongoing, and there were members who were members of the RAC and also members of the work group. So we moved the first work group meeting for the quantitative data reporting template to next week. I believe it's on the 28th now. And if it is decided at, that work group or at future work groups that, a waiver process isn't needed and you really just need to indicate 0 on the template, I think we can update this language before we finalize the rule. We'll probably know that from the quantitative data reporting template work group. So we can just update the language here to indicate, the correct process for carriers.
Okay, great. Thank you.
Go ahead, Gary.
Hey, Gary, sorry. Hey, what I was just thinking of, Brooke, is the way this is written is a carrier may request a waiver. First, do we want to require them to file no matter what? Because we're just requesting them. And then the second part is carrier. I'm looking at if we're unintentionally bringing in a lot of other carriers that don't issue health benefit plans. Because I was looking at the definition in the rule, it just says carrier defined in 74300B or 5. So if we're unintentionally bringing other people, they're going to have to give you guys, waivers when they really never offer health benefit plans. Something to think about.
Okay. That is, yeah. Thank you, Gary. I appreciate that. I'll take a look at the definition and yeah, I do believe that you're correct that we probably, instead of may request, that is likely something that we should require. So I appreciate that as well.
Okay, and just clarify, I just looked in the statute and carrier does point out it's a person who provides a health benefit plan. So that's okay. It's just the requesting versus required.
Got it. Thank you, Gary.
Thanks.
Any other feedback on this section? All right, so if we scroll down to, I believe the next changes are in the this rule right here, the behavioral health network and composition. We just added right here, if you scroll down to the highlighted section, in 1C, we added 4 here, which was updated to include LGBTQ plus individuals, gender diverse identities, and sexual orientations among the populations carriers must report on. And this was a request by a RAC member, but it also was a change that was made because of the deletion from the reporting rule included LGBTQ plus individuals and gender and people with diverse gender identities and sexual orientations. So we're just making that update since it was deleted from the reporting requirements. Melissa, go ahead.
This is just minor. I noticed when I was reading through it, if you scroll up to the list of the types of providers, psychiatrists you might want to revise that to include like psychiatric mental health nurse practitioners as well as physician assistants, just because, or there could be a term psychiatric providers, which might encompass all of them. There's precedence for this in some of the what is in the behavioral health parity sections, but psychiatrist typically refers only to MDs or DOs, and I want to just make sure that everybody who is a psychiatric provider gets encompassed.
Okay. What do others think about that suggestion? Because I believe that this list was pulled directly from the statute itself. And so the statute itself lists licensed professional counselors, licensed marriage and family therapists, licensed clinical social workers, psychologists, and then it does say psychiatrists. It doesn't kind of delineate it out the way that you're talking about, Melissa. So do others have thoughts about Melissa's suggestion here? Go ahead, Gary.
Yeah, I think it may depend what we're trying to get at or what you're trying to answer. If you need to go to that level, there may have been reasons why they kept it at the psychiatrist as going to other levels. That's the only thing I'm thinking of is why they did that instead of just saying a psychiatric provider. So I think it would go back to what are we trying to answer if we get the information at this level. So I'm open, but I think we would want to just justify why we did go to those psychiatric providers.
Okay. Thank you for that, Gary. Does anybody else have thoughts? This section, so that this it was added to the statute as a part of HB 3046 in 2021, I believe. I don't, off the top of my head, recall the conversations with the legislature around why this was added to the statute, but I think I can probably go back and see if there's what the legislative intent was here, and then we can kind of have a further conversation about your suggestion maybe at the next RAC, Melissa.
Thank you. Yeah, and I would have to go back and look as well. It's just my understanding is psychiatrist is again that MD level, and it is Gary's point is a good point, whether we are wanting to confine it to them, the MD DO level, or if we are wanting to look at other levels of psychiatric providers as well.
Any other thoughts about this section or Melissa's suggestion?
I would say, yeah, I'll say that I tend to agree with what Gary said. And I appreciate Melissa expanding on possibly the purpose of it, but it just, I think we should just not go beyond psychiatrists. Just stick with that scope. Yeah.
Okay, thank you, Antoinette. Right, if we scroll down, I think the last change that was made to the rule is in the provider directory requirements. In the highlighted section right here, this was just updated to include current language. I think mental was changed to behavioral because that's how we define it in our own rules. It's behavioral health conditions. And then we just added individuals with specified physical or behavioral health conditions. Any thoughts or feedback about this change? Scott, go ahead.
Hi, Brooke. Scott White from Motor Health. Just with all of this, I guess just the understanding that this is only as good as the information we get from providers, right? So, you know, yes, we'd love to have all this information. We frankly just don't always get it. And I just want to make sure that's addressed or understood as we move forward with this.
Yeah, thank you for that, Scott. We do understand that the provider director information is only as good as you know, the information that providers are willing and able to share with you. And I think we've had, you know, in-depth conversations about that at the RAC as well. And so yes, that is something that we understand.
Okay,
go ahead,
thank you.
Antoinette.
Yeah, and for those providers on the call, could you possibly expand on what those physical or behavioral health conditions are? It's just a little bit vague to this average person that works for commercial payer.
Do any of the providers on the call want to try to answer that? What a specified behavioral, physical or behavioral health condition would include?
Because I'm getting that, you know, if we put this on a roster for a provider, you know, what kind of specificity or guidance do we need to give to the provider as to what we're expecting back?
I think that's a great question, Antoinette. Go ahead, Betsy.
Yeah, Betsy Boyd Flynn from the Academy of Family Physicians. I wonder about this language as a potential and the potential privacy implications if we're asking providers to self-disclose this kind of information. Having said that, given that some some kinds of care or modalities of care might be, the cultural concordance might include a physical or behavioral condition. So if, for example, a provider is on the gender spectrum rather than cisgender, that might matter to a patient who is looking for care in a place that they can find cultural conformance. I think as long as that sort of disclosure is voluntary to the clinician or to the provider, I think it's okay to ask for that, but I hesitate to require carriers to know that information, particularly in the environment where we are, where some of those kinds of identities or diagnoses might, in fact, expose someone to discrimination or even legal exposure.
Yeah, thanks, Betsy. I appreciate that. Yeah, that is something to keep in mind as we're looking at this. Go ahead, Melissa. I think you were next.
Yeah, my understanding, if we go back and look at H, is that this is asking providers to identify their clinical focus, not to identify anything about themselves. Maybe having the self-identify piece there makes it a little bit confusing, but I think that I can see what you're trying to get at, that around the insurer's concerns that they would be held responsible, and so maybe that language still needs to be considered, of like, just the specifically what we're saying in H, and making that very clear that we're asking about the provider's clinical focus. And then speaking to what Antoinette said under individuals with specified physical or behavioral health conditions, I can just say more on the behavioral health side, that there are certain behavioral health conditions that require I'd say specialized training and knowledge to treat, that not every behavioral health provider is going to have the knowledge to treat. And so some of those things might be something like even like obsessive compulsive disorder. People who have OCD are often looking for clinicians that have specialized experience in the specific treatment modalities for OCD. And so that would just be one example where a clinician might say, hey, I specialize in treating OCD.
Thank you, Melissa. I appreciate that. And Seth, I saw your hand come up and then come back down. Did you have something to add, or did was it addressed elsewhere?
I think it was just addressed with the self-identifies. This is about having a clinical focus in serving this area, not having a personal identity, which I think would be important here. And I think it's important that it's optional, as providers are seeing surveillance risks in other states, and so may opt out for that reason. But it's important for those who do want to advertise they're serving this population that patients be able to find them in this network.
Yeah. Okay. Thank you, Seth. I appreciate that. And I appreciate everyone's feedback in this area. I think I'll take a look at this language and see if we can tighten it up to make it clear that what we're asking for is if the provider does have a clinical focus that they want to kind of advertise to potential enrollees. So I will take a look at this and maybe provide some potential changes at the next RAC meeting. Any other thoughts about this section or any other areas of the rule that we talked about? Go ahead, Antoinette.
Yeah, I have a quick question for Melissa, explaining what this mean on the behavioral side. And again, I'm learning, Melissa, and I've learned a lot through all of the providers on this call, so I really appreciate it. But by reference to clinical focus, does that really mean that your specialty? Is that what that language means, clinical focus?
Well, so we've been talking about about how we can sort of create a situation where where your provider directories might have more information for members who are looking for certain things, because like, for instance, if we say something like anxiety, you're probably more likely to find a lot of behavioral health providers who can treat anxiety competently and who have experience and training to address anxiety. But then there may be some other behavioral health conditions that like I used OCD as an example, that might require a little bit more specialized training. And so, you know, I see how the department removed specialized experience, which I supported that because I understand, particularly on the medical side, that there may be that may be a protected term, but really ethically, and I think when we look at board standards, because we're all held to standards by our licensing boards as well as our professional ethics. You know, we are not supposed to practice outside of our scope. And so it's really on us to be able to say whether we have the experience to practice in a particular area or to treat a particular condition. So like for another example that I would consider where you would really need some specialized training and experience would be like eating disorders, for instance. I wouldn't feel comfortable working with somebody who has, you know, a serious eating disorder. I could work with somebody who has some concerns in that area, but if it's like a diagnosed eating disorder, I don't feel comfortable treating that. And if somebody came to me saying, hey, I have an eating disorder, can you treat me? I would say, I don't feel comfortable with that. That's a bit outside of my scope. I would try to give them referrals to colleagues who do have that experience. And so it's one of those things where you know, it is a lot of professional judgment. And then the other part might be that we can get specialized training. Like maybe I've taken a special interest in OCD and I've pursued continuing education and specialized training specifically in OCD. And then I can put out to the community that I have a specialty in OCD, but because in behavioral health, that term isn't really protected term. I can't speak for the medical side. And so that's why we kind of, I think, settled on clinical focus. So I would say, hey, I have a clinical focus in OCD. And then that would hopefully draw more clients with that need to me. I hope that's helpful, Antoinette.
Yeah, it is. You know, it seems like clinical focus is the big umbrella and everything fits under that. Oh, can you hear me okay?
Yeah, you got quiet for a second.
Oh, okay. It seems like clinical focus is the umbrella and everything fits under it, you know, and I'm wondering whether for us, when we submit that roster, maybe also put in something like, you know, or specialty, clinical focus or specialty, or including specialty or something like that, you know, while Brooke is thinking about how do I craft this so that it's a little bit more clearer and less, you know, vague.
Yeah,
Oh,
I think this is something we're continuing. Oh, I'm sorry, you're cutting out, Antoinette.
oh, I am so sorry, and I'm done. I think I just had a dental surgery, so that could be the problem too. So sorry. So sorry. Yeah. So I think I'm done. I'm done speaking. I think my message, hopefully it's clear, and Brooke knows how to take it from there. But thank you so much for explaining this again. I continue to learn, and I appreciate it.
I appreciate it too. I appreciate the questions because I think that you know, those of us, it's like we see things from our perspective and we know what we're talking about. That doesn't mean other people know what we're talking about, right?
Yeah, and I appreciate that, Antoinette. I appreciate your explanation too, Melissa. I will again take a look at this and see whether or not changes are necessary. I do agree that, you know, perhaps clinical focus might not be the correct terminology here. I know we already changed it from specialized experience, but perhaps there's another way to kind of craft this language so it addresses what we're actually getting at. And I will take a look at that. Any other thoughts about the rule? Okay, so those were all the changes to the rule. So we will move on to the next section of the agenda, which I believe is the review of the statement of need and fiscal impact. So before we finalize the statement of need and fiscal impact for this rulemaking, we want the RAC's input to ensure that, you know, when I write the statement of need and fiscal impact, that it is clear and accurate and it does reflect stakeholder perspectives. So just for everyone's knowledge, there are kind of two parts to this. It's there's a statement of need, which should explain why the rule change is necessary and how it addresses the identified problem. And then there's also the fiscal impact section, which should outline who might be economically affected by the rule and provide enough detail so that those parties, when they're reading the statement of need and fiscal impact, could evaluate how the rule may affect them. So for the first section, does anybody have any feedback on what should be included in the section about what the rule is trying to address and how the proposed changes address that need? Okay, hearing none. For the fiscal impact section, is there any feedback about who the rule may affect fiscally, whether that's state agencies, local governments, or members of the public? Go ahead, Melissa.
Sorry, I wasn't I wasn't completely ready to talk about this off the cuff, so I had to kind of gather my thoughts. But going back to the how it will affect equity in the state, I think that you know, in keeping with the mission of OIMHP, we are always very concerned about you know, people with behavioral health needs having the same access to care as people with other types of needs, using our insurance system and really wanting people to be able to access affordable in-network care using their insurance, being able to find providers who can meet their needs, which is why I feel motivated for us to keep working on that section and getting the wording right. Because like I said, with my example of if I'm a provider trying to refer somebody who's come to me, it's not meaningful for me to just be like, go look at your provider directory and there's just like a sea of names, you know, and it would be so much more useful for them. And I don't know, you know, what this will end up looking like in reality, but ideally it would be so much more useful if they could say, oh, look, here are these people who have this specialty that I need. And so the work that we're doing and the network adequacy and that behavioral health section, I think will help people who have behavioral health needs have more equitable access to care.
Thank you, Melissa. I appreciate that. Any other feedback, either on the economic impact or the impact to equity? Okay. I'm hearing none. I think we can move on. So for the cost of compliance to small business, it asks us to identify any state agencies, units of local government, or members of the public who may be impacted by the rule, and also the number and type of small business that are subject to the rule and how they may be impacted economically by the rule. Does anybody have any feedback about this section, about whether the rule would affect small business and the economic impact of that, or the impact to the other entities listed here, state agencies, units of local government, members of the public? Okay. Hearing none, if anybody has any feedback about the statement of need and fiscal impact after the RAC is concluded, you feel free to let me know. You can just email me and let me know, or you can include it in your comment letters about the rule. So I think we can move on to the next section of the agenda, Karen, which is, I believe, the public comment section. So now is the time for members of the public to provide comments or feedback. Is there any member of the public that would like to do so? If so, please raise your hand and I will call on you. Natasha Mayfield.
Sorry, I was just making sure my audio's on properly. Can you hear me okay?
Yes, we can hear you.
Great. I'm Natasha Mayfield. I've been tracking this pretty closely since the RAC started. And I have a couple of questions that I've just kind of quietly been observing. And I should also share, I work in the healthcare industry. Essentially, what I do is help make sure that new innovative clinical care models actually reach patients and that they work from a business perspective as well. So my two questions. One, can you clarify a bit more for the public perspective as to why the approach for enforcing the rule is going to be managed through essentially self-governed reporting from the carriers? And as part of that, can you also help clarify how that reporting is going to be ultimately reviewed and handled from an administrative perspective? So that's basically part one, and I'll wait.
Yeah, thanks for that question, Natasha. As to the reporting, that is outlined in the statute itself, and self-reporting is how network adequacy information was reported previously. It's also how we do most of the reporting related to our rule. We also do self-reporting in the behavioral health parity rules as well. And so it's kind of the process that was outlined by the legislature, but it's also, the process that carriers and the division themselves most often use. As to the second part of your rule, I don't believe, so Cassie Susie is the manager of the unit that would be reviewing the information provided by carriers. I don't know if she's on the call. Cassie, are you on the call? Okay, do you want to repeat that part of your question again, Natasha, for me?
And I can add a little bit of context as well, if that's helpful. Basically, one of the things that I am concerned about as a member of the public, and also just trying to, as I understand the intention of this rule, is that it's very easy to submit reports that are never actually fully monitored and then followed through on. And the way to strengthen accountability is usually through more focused, like random audits. It's the same way that carriers audit providers in their network as well, where that's always part of the provider agreement, whether it's a pharmacy, whether you're talking kind of medical benefits, et cetera. And so you just like, the reason for my question is more around, one, the reporting itself is going to drive administrative complexity and require appropriate staff that understands these nuances to then oversee it, investigate it, follow through, et cetera. And often there's a big lag there. Two, in my experience, more focused, targeted random audits are much more effective way to drive compliance while still balancing resourcing. And it's very similar to how carriers approach managing their provider networks. And so that's kind of where that question is coming from. And then I do have one separate question, but I'll let that pause for you to kind of note that down or ask any clarifications.
Yeah, I appreciate that. What I will say is that we do have a team of market analysts who will be reviewing all of the information provided by carriers. This is a newer process for us, so I anticipate that it will likely take some time to kind of, one, understand the information that we're receiving, two, understand if it's the right information, right? Because again, this is a new process for both us and for carriers. And so it's going to take some time to kind of ensure that we're getting the correct information, and then two, to kind of go through all of the information that is provided, to ensure that networks are adequate. But we do have a team of market analysts who do look through that information. They'll be looking through it on a yearly basis. And the process that we kind of have used in other areas that we regulate is, we review the information provided. We work with carriers to, if there are any questions that we have or any, gaps in some of the information that was provided by carriers. The market analysts kind of go go through and determine whether they have any questions, you know, that need clarification. So that would be the first step, and then it would be reviewing kind of all of the information provided by carriers for you know, to ensure that networks are adequate. There is some areas of the reporting that kind of would be random, like you're saying. So the process for I think it's the appointment wait times includes carriers hiring a third-party survey company to kind of do surveys of providers to see, you know, when the next available appointment is. And so there is randomness to some of that information that is provided to us. So, but again, this is a process that we'll kind of be refining probably over the next couple of years because it is new for both us and for carriers. So I hope that answers some of your question. Cassie's better suited to answer kind of, you know, the intricacies around, you know, how the market analyst teams work and the information that they'll be reviewing. So I'm happy to kind of maybe get back to you with what information she's able to provide.
That. And then, so I'll ask or share the second question. And really where this is around is I'm looking at the rule from the perspective of having helped healthcare clinics and providers' offices that struggle with network access today. So for example, one of the things that I was looking for in this rule is to try to better tighten up or understand that when an insurance company has determined that a patient is clinically appropriate for care through prior authorization, predetermination, et cetera, there are still instances where they may not actually contract with a provider who's like qualified to provide that care. So from a patient perspective, the temporary rule accounts for that to make sure that the patient can't be essentially billed for an out-of-network provider. But the ultimate catch-22 is if the provider can't be contracted as an in-network provider with the carrier and the carrier is unwilling to do that, the provider is not going to be able to deliver the service pretty much anyways, because there's no guarantee of payment for them and that can be paid at a different rate. So what I wanted to try to understand is how to tighten up specific scenarios, because there's a lot of like types of clinical areas of focus, I think was the term used today, but there are still some specific scenarios that I could see falling through the cracks here where ultimately the insurance company has said, yes, we agree this is a clinically appropriate, you know, therapy or treatment plan for the patient, but then there is no actual contracted provider within the appropriate geographic region to be able to provide that care. So I wanted to see if there's a way to try to tighten that up in that scenario to kind of bring that accountability. And then as part of that, see if there is an avenue that could be formally part of this rule, that if a provider is trying to contract and they're getting the commentary from the insurance company that they're unwilling to contract with them. I can share other examples of this where it's not unique to a provider. It's unique to a whole class of care that they've been unwilling to contract, that the provider has some sort of formal pathway to report this for further inquiry and investigation as part of the rule. So that's the other aspect that I wanted to try to bring forward.
Yeah, and I appreciate that, Natasha. What I will say is that I think that that is probably outside the scope of this rule. The rule itself does not require carriers to, you know, to contract with any available and willing provider. It requires them to ensure that they have enough providers for all of the services in their benefit plan. And so, you know,
I think that's where I'm trying to say it's actually the same thing though. If they've agreed to cover a certain benefit, but then there's an unwillingness to contract with the providers that provide that benefit, how do we ensure that's accounted for?
Yeah, and that would be where our review of the information reported to us comes in, because that review would be looking to ensure that, again, that they have enough providers to provide services for all enrollees related to the services covered under the benefit plan. And so we'd be reviewing the information provided by carriers to ensure that that is accurate and true. But we don't have the ability to say that carriers must contract with any available and willing provider. And I see a bunch of hands, so I'm gonna stop and let people kind of jump in if they want to. The first one I see up is Antoinette. Go ahead.
Yeah, thanks, Brooke and Natasha. I appreciate the questions, and I think some of your concerns. And I agree with Brooke. I think this is out of scope of the rulemaking. Or the RAC, and maybe if the DFR can touch bases with Natasha one-on-one and just kind of give her a run through of our current reporting, which and also the process, et cetera, that would be great. But I think it's outside the scope of this RAC. So that's all I wanted to say. Thanks.
Yeah, appreciate that, Antoinette. And I agree. I think it probably would be great for me to follow up and maybe have Cassie available so she can kind of give you some further information on what it looks like after we've received information from carriers and what the process is to review it. And so if you want to pop your email into the chat or just send me an email with, then I can reach out after the RAC. Go ahead, Seth.
Yeah, just sort of thinking about the second question there. If a carrier reports an HPSA, a shortage area, but providers exist and have had trouble contracting and reach out to us as an advocacy organization, is there a reporting place for them to go? I think that's just something that's still sticking in my mind from what Natasha shared, and that how does the provider's experience contrast the HPSA waiver request?
Okay, so is your question, sorry, I got distracted, Seth. So your question is if providers have an avenue to kind of reach out to DFR, and is that the question? I apologize.
Yeah, I think that's what I'm picking up in the second question that I find interesting is we have had some folks who've been going into the field of providing more gender affirming care and having an impossible time contracting or becoming an out-of-network provider who can bill appropriately. But let's say that carrier has deemed that area, potentially in Eastern Oregon, a health provider shortage area, and filed for exemption. So just kind of curious if there's a contrast where a provider might reach out or who they would reach out to.
Yeah, thanks for that, Seth. So we don't typically, get involved in kind of disputes or complaints between providers and carriers because that's not our role. But what I will say is that we have, we do receive kind of complaints or feedbacks from providers on a pretty regular basis. And there are times when we have kind of because of information that a provider has given us, we've, gone back to carriers to ask for additional information or, provided clarifications. The way to reach out to us is the same way that members would reach out and provide a complaint. It would just be, through that email, the complaints email, which I can send to you, Seth. But that's probably the best way. And then once a provider, does reach out, then we would kind of determine whether or not it's a situation or a role that warrants kind of further investigation or further clarification from carriers. I hope that's helpful.
Yeah, thanks so much. I was just curious about that second question.
Yeah, go ahead, Melissa.
Yeah, I'm just trying to go back to a previous conversation that we had about the health provider shortage areas and what carriers are required to report. And I know that I had made a suggestion that because it seemed like most of what they were required to report were like things like provider unwilling to contract. And then I had said, you know, it would be nice to include in that report if there were any barriers on the insurer end, including, you know, administrative barriers or long times to credential or contract. It would also be nice to know, and I don't know if this gets reported when carriers close networks, because from behavioral health providers, I have heard, you know, in various places that they would apply to be credentialed, and then they were told that you know, that the network was closed, and so I don't know why that decision gets made. They have reported that they're told that there's already enough providers. So I don't know how those decisions get made, and if those are if carriers are required to report that. But I think what I'm hearing is that, you know, we're wanting information coming from sort of both sides, right? Like, because if the goal here is to give the public more access to care and to make sure that it's equitable and that people who have lots of different needs are able to access care, we want to identify where the barriers are, whether they are coming from the carrier side or the provider side, or if it's a geographic issue. So that's just where my mind is going. And maybe I got a little bit lost on what we ended up doing with the healthcare provider shortage areas.
So it is outlined in the rule, what carriers are required to, what information they're required to provide when asking for an exception. And we're running out of time, Melissa. So I think instead of going over that right now, I'll just reach out to you, but I will note that it is outlined in the rule, the information that they're required to provide. But I'll reach out to you and we can have a further conversation about it, Melissa. All right, so we are running out of time. I will just go into next steps if that is amenable to people. So the next steps, any feedback on the rule, please provide to me by Friday, February 6th. We're not going to hold a RAC meeting in February because session is starting, and obviously it's a very busy time for all the carriers on the call, for the advocates on the call, and for me as well. And so if we need another RAC meeting, it won't be until March, but we'll let you know after hearing about feedback on the rule. And again, the first work group meeting for the quantitative reporting template work group will be on January 28th from 1 to 2:30. So if anybody on this call, you know, I know that some of the carriers identified representatives for that work group instead of having themselves on that work group, but please, a meeting invite has been sent out with updated dates, but just let your people know that that work group meeting was changed and it is now next week. So any questions before we end? Go ahead, Antoinette.
Yeah, quick question, Brooke. So given the deadline, well, given the timeline, due to the current rule being temporary, I think the DFR has 180 days. So when is the anticipated completion date of the rules itself, so that it can start that formal process in becoming permanent with the Oregon State, God, I forgot the division, Secretary of State, sorry.
So yeah, you were correct. We have 180 days from when the temporary rule was filed. The temporary rule was filed, and correct me if I'm wrong, Karen, but in December of 2025. I think that means we have until June for that 180 days to be up. I anticipate that we'll probably have a finalized version of the rule before June. I don't think we're that far away. I hope others don't either. And so, you know, perhaps we may need one additional RAC meeting, but I think it'll be finalized before that June deadline, Antoinette.
Great, okay, thank you. And this would apply to the effective 7/1 and going forward. And our first reporting will be based on, well, I guess it's to be discussed during the template working group, but I'm anticipating that it would be the first report that will be due based on the rules will be in 2027 based on 2026 data.
So the first report that will be due will be in 2026, but as we said in previous, right, it will be in 2026. I
No,
believe.
because, well, we are doing the 2026 reporting right now based on 2025 data. I saw it.
Yeah,
Okay.
but it doesn't include the quantitative data.
Correct.
So, yeah, correct. So it's a kind of a pared down version of the report that doesn't include the quantitative data. The first time the quantitative data will be due will be in 2027.
Okay, thank you.
All right, with that, I see we're a little bit over time. I appreciate everyone for staying on. Please let me know if you have any additional questions or comments. Feel free to reach
Okay.
out via email. Karen, go ahead.
I had seen a hand go up from Gail
Oh,
while we were in the public comment phase. And so I don't know if she had a question or if she had some comments to make.
apologies, Gail. I didn't see that. So go ahead.
Hi, I just had some questions around the quantitative standards and how the network adequacy would relate to Senate Bill 1137. But I did just send an email on that. I wasn't sure if the work group would better establish those standards that would be used for that bill.
Yeah, I appreciate that, Gail. I will read that email and I'll reach out to you. We can have a conversation about it after the RAC. So I
Okay.
will reach out separately and we can talk about it.
Thank you so much. I appreciate it.
All right. And with that, I think we're out of time. So thank you, everyone. Appreciate your feedback today. And please comments by Friday, February 6th. Thank you.
Thank you.
Thanks.